Oh. Hello, how are you doing? Welcome to Levine Museum of the New South's ongoing pandemic response, shaping Charlotte COVID-19. The ongoing pandemic is revealing the shortcomings to our healthcare system, but access to healthcare is a long-standing issue that has been affecting the overall physical, social, mental health status, and quality of life of communities across the country. Join us as we discuss barriers to healthcare in the COVID era and the work that is required to dismantle them. I would like to start off by thanking our sponsors, Bank of America and the Arts and Science Council. Their support has been integral as we continue to transition into these virtual events and virtual programming. As always, with our programming here at the Levine Museum of the New South, we like to have lively, interactive discussions with our audience, but we of course want to start by grounding our conversations and discussion in history. So with that said, I would like to introduce our first guest, Dr. Jessica Sachs. Dr. Sachs has worked as a family physician for the underserved for Carolina's healthcare systems for 34 years before she retired in 2015. In practice, she saw daily examples of people who did not get needed care for financial reasons, which strengthened her conviction that everyone should have access to healthcare. She chairs Healthcare Justice NC, which advocates improved Medicare for all as the most effective, economical way to extend high-quality healthcare to all. It is a chapter of Physicians for a National Health Program, of which she is on the national board. She has won many awards, including the Council for Children Dolly Award for Child Advocacy, the Mecklenburg County Medical Society President's Award, and the YWCA Women of Achievement Award. A graduate of Oberlin College and Tufts University of Medicine, she did her family medicine residency at Duke University. With that said, I would like to thank Dr. Sachs and welcome her to the program.
Thank you, Braxton. I'm so glad to be here. And I just want to reiterate one of the things you said in that nice introduction, which is that when I was in practice, every single day, I saw somebody who didn't get some kind of health care that they needed because of cost. And that was despite the fact that I worked in health centers that were set up to take care of the people who were uninsured and underserved. So this topic is not an abstraction to me, and I'm very glad to have the opportunity to talk here about the history of access to health care. So in a minute, I'm going to summarize about 100 years of health reform efforts. But first, I want to start you all off with a couple of questions to think about. And I'd like to ask you, as I speak, I'd like you all to think about what you think about how our healthcare system developed. Do you think that somebody sat down and said, well, let's figure out what the best system for the United States is, and came up with a logical plan that gave us a system based on employer-sponsored insurance? So give that a little thought. Before I talk about the United States, I just want to give a little context here, which is that in Europe, European countries started developing sickness protection plans in the late part of the 19th century, not the 20th century, the 19th century. And it started in Germany, where they developed a national health plan in 1883, and then basically all the other European countries followed. Now, we didn't have that kind of planning. We had some voluntary efforts, but not big public efforts at that time. And the reason is probably because we didn't have as strong a labor movement as Europe did. But we did have some efforts. Teddy Roosevelt was interested in developing a national health plan in the very early part of the 20th century. That didn't go anywhere. But in 1915, there was an organization that developed a plan for a national health plan. And initially, the AMA favored it and favored compulsory health insurance. But that was the national organization, but their member societies opposed it. And so the AMA backed away from it. And then they denied that they had ever been in favor of it at all. In 1917, it met with a lot of opposition. And the reason was because of anti-German sentiment, because national plans had originated in Germany and there was this war with Germany going on. And then after that, there was anti-communist sentiment. So I want you to pay attention to what I've just said about opposition, and as I talk, see whether you think that there might be a theme developing here. During the Depression, Franklin Roosevelt thought about putting health insurance in the Social Security legislation. However, the AMA opposed it, and he thought that the bill wouldn't pass with it, and he pulled it out of the bill. And in the following years, there were other bills that would have provided health insurance to everybody in the country, including one that was introduced in 1943 and then for 14 years after that. The opposition called it communist, and it didn't pass. But something else was going on in the United States that was very relevant to this. During World War II, Roosevelt froze labor wages. So companies started offering health and pension benefits, which were not frozen, and that was a way for them to retain and attract workers. Not everybody in the country got covered by that, but the unions were getting benefits for their members, and so the unions weren't pressuring the government to create a national system. In 1945, Truman proposed a system that would cover everyone. The AMA opposed it, and they launched a $1.5 million lobbying effort, which at the time was the most expensive lobbying effort in American history. They had one pamphlet that said, "Would socialized medicine lead to socialization of other phases of life?" Lenin thought so. However, there was support from one part of the medical community. The Black community had been living with segregated inferior resources. Dr. Montague Cobb, let me repeat that, Dr. Montague Cobb, who was a great leader in the National Medical Association, the Black Medical Association, defended Truman's plan. However, it died in committee. The next serious attempt to reform healthcare was during Kennedy's administration. Costs of healthcare had been escalating, and of course the people who were most affected were the elderly and retired people who didn't get benefits through work. So there was a move to start Medicare for the elderly. Once again, the AMA even opposed that narrow plan, and they used an actor named Ronald Reagan who delivered impassioned ads pleading with people to reject socialized medicine. After Kennedy died, there was a national mandate to fulfill his goals. President Johnson was a strong supporter of Medicare, and though the AMA still opposed it, it was supported by public health officials and by nurses. And there was also support from another corner of the medical establishment. Dr. Montague Cobb was now the president of the NMA, and he led Black doctors in supporting Medicare. It passed in 1965 with Medicaid for the poor added on. Johnson flew to Independence, Missouri, where Truman was, for the signing, and he presented Truman with the very first Medicare card. There were no members of the AMA there or invited, but Dr. Montague Cobb was there. Now, because of that alliance and because of the very hard work of the civil rights movement, hospitals were required to desegregate to receive Medicare funds. And there was considerable anxiety before the implementation of Medicare about whether Southern hospitals would actually go along, but they wanted the federal money, and that's when hospitals integrated. For many of the people who worked on that legislation, Medicare was supposed to be the beginning, not the end, of wider insurance coverage for the country, but in fact, it was the last piece of really major healthcare legislation until the Affordable Care Act. Teddy Kennedy took up the campaign for national health insurance, and in the early 70s, it actually looked like there might be a Democratic and Republican compromise to bring it about. But Nixon got a little distracted by, and then totally consumed by Watergate, and nothing passed. In the Reagan years, programs were slashed. Democrats made some attempts to restore some health care. And then Clinton was elected president, and he established a health reform task force, which was co-chaired by Hillary. That task force developed a plan that was supposed to be a compromise between the market forces and the government oversight forces. But instead of a compromise pleasing everybody, the plan got attacked from both sides, and it failed. The Bush years brought an addition to Medicare with the addition of a drug benefit, and that did get bipartisan support. Many concessions were made to the drug industry, including prohibiting the government from negotiating drug prices, which all other countries do. But that lack of ability to negotiate has contributed to the fact that there's such inflation in our drug prices and why they're so much more expensive than in other countries. Now that now brings us to Obama's health reform efforts in 2009. And although there was some diversity and representation in the planning, no one who advocated a single payer or a Medicare for all system was invited to even the early negotiations. As they developed a plan, there was criticism from all directions, including, and I know you'll all be surprised by this, including an accusation that whatever they came up with would be socialized medicine. Obama had envisioned bipartisan support, and that was plausible since the plan they came up with was actually based on the Massachusetts plan that had passed under Republican Governor Romney. And before that, in 1974, Richard Nixon had proposed universal health care coverage, which included an employer mandate, which was very similar in some ways. However, when the Affordable Care Act passed, it had only Democratic votes, and many people on both sides considered it to be a very flawed bill. So the key elements in the ACA are individual and employer mandates, which required people to get private insurance, and another major element was the expansion of Medicaid. But then the Supreme Court ruled that states couldn't be required to accept the Medicaid expansion. Most states eventually came along, but there were a few holdouts, including North Carolina. And that's why we find ourselves with hundreds of thousands of people who are uninsured, even before the pandemic. One major outcome of the ACA, also known as Obamacare, has been to decrease the number of uninsured by millions, mainly through the Medicaid expansion. However, in recent years, and even before the pandemic, we've seen a creeping up of the number of uninsured, as well as an increase in the underinsured. Those are people who have insurance, but still can't afford health care. Well, that's been kind of a race through over 100 years of history, and I think you'll see a couple of common themes. One is that every effort at health reform has been opposed by calling it socialism, and that applies even to Medicare, which is not only generally accepted, but is the most popular health insurance plan in the country. And also, it's been an objection to the Affordable Care Act, despite the fact that one of the fundamental parts of the plan has been the mandate for people to have private insurance. So at the beginning, I asked you to think about how you think our healthcare system developed the way it did and whether it was some logical plan. But I think that what you can see is that it was really an accident of history that led to the offering of health benefits by employers during World War II, and then that brought us to the reliance on that and for support for those plans that people already had. So I just want to say before closing a word about where we are now. We have a system that we think of as being employer-based. A few months ago, about 160 million people were covered by employer-sponsored insurance. Now note that was before the pandemic, which has changed things. However, 2/3 of our healthcare spending is actually public spending, not private. That's like Medicare, Medicaid, health insurance for government workers, the VA. Our system is by far the most expensive in the world. It costs about twice as much per person in this country as other developed countries. And about 1/3 of our spending is administrative costs because it's so complex. Now, 1/3 of a lot of money, in this case, is $1 trillion. And about half of that is wasted. And for all our spending, we have much worse health statistics than other developed countries, worse infant mortality, life expectancy, and they're much worse for minority populations. So I just want to end by saying that the United States needs to join the rest of the developed world and have a national system, not socialized, but publicly funded private delivery. We could achieve that with improved Medicare for all, which would cover everyone, be affordable, save money for the country and individuals, and cut down on racism and racial and ethnic disparities. And I hope that you will look at the, as I said earlier, I'm a member of Healthcare Justice North Carolina, which advocates this. Thank you for putting that up.
You mentioned there at the end, I was going to ask you a question about the existence of this employer-based tying access to medical care to employment. And it seems like a very American thing, even as you say, some of the public funded healthcare access, the VA, that has some kind of tie to your previous past employment. Is access to medical care tying that to employment? Is this a historically an American creation, or is that something that has some roots somewhere else?
No, it's very much an American creation, and it's very much kind of an accident of history because of what happened in World War II. But no, other countries absolutely do not tie healthcare to employment. And just skipping ahead to what the effect of the pandemic is, I would just say that in this country, it's estimated that about 27 million people lost their healthcare insurance from losing their jobs in March and April. And that absolutely did not happen in other countries. Even people who lost their jobs kept their health insurance because it wasn't tied to employment.
Thank you, Dr. Sachs. Thank you for going through that history with us. I do want to take the opportunity now to bring some other expert voices into the conversation so that we can hear what the effect of that history is on their opinion. I'd like to first start with introducing Dr. Saju Joy, who currently serves as the Chief Medical Officer for Atrium Health's Central Division, which covers CMC Maine, CMC Mercy hospitals here in Charlotte. He is also the co-chair of the Perinatal Safety Collaborative system-wide and leads the capacity surge management and clinical optimization for women's health in the Charlotte metro area. Dr. Joy has been part of the Atrium Health medical community since joining CMC and the Women's Institute as an OBGYN and maternal fetal medical specialist in 2010. He has held more than a dozen leadership and committee posts during his tenure. Dr. Joy received his Bachelor's of Science in Computer Engineering and a Master's degree in Electrical Engineering from North Carolina State University. He received his medical degree from the University of North Carolina. He recently completed his executive MBA from Duke University, rounding out the triad triangle. So I think you might be a bit confused when it comes to the PC tournament. So that might be a conversation there. Welcome, Dr. Joy.
Thank you, Braxton. Yeah, I do have the triangle covered, don't I?
Yeah, it seems like it. It seems like it. It seems like it.
Well, no, it's a privilege to be here, and I really enjoyed the history that Dr. Sachs just went through. I appreciate that.
Cool. Thank you very much. I look forward to your contributions to this important conversation. But before that, I want to introduce our other guest, Natalie Moralist, who is originally from Bogota, Colombia, and came to the U.S. in 2004 after graduating from nursing school. In 2017, she co-founded El Puente Hispano, a nonprofit organization to further help Hispanics in Cabarrus County. Moralist also serves as a vice chair of Enlace CLT, a coalition of organizations serving the Latinx community. In 2016, she received her paralegal certificate from Charlotte School of Law and graduated magna cum laude with a Bachelor of Science in Criminal Justice from ECPI University. Before joining Charlotte's Center for Legal Advocacy, Moralist served as an intern at the Mecklenburg County Courthouse, working with the Family Court Administration. She has also interned with Union County Sheriff's Office and served as a volunteer with Guardian at Leadham for 2 years. Outside of work, she enjoys spending time with her husband and their dog, a Jack Russell Terrier named Sparky. So welcome, Natalie. Welcome to the conversation.
Hi, thank you, Braxton, and thank you for the invite.
Oh, okay. Pleasure. So first, I'd like to get Natalie and Dr. Joy's a reaction to that history. Was anything surprising, or does this pretty much line up to your experience?
Natalie, if you'd like to start.
Yeah, it's pretty much kind of like the same theme that we see over history. And unfortunately, healthcare is always seen kind of like the theme for the political parties to deal with. So, and that's unfortunately because the people in the US is the one that is suffering right now because of all these decisions that is making in the legislature. So, yeah, it's kind of like the same theme over and over again.
Yeah, and I mean, healthcare, in my perspective, is a God-given human right. And when we put barriers into making that more difficult, I feel that it's an injustice. And that's also why I have a lot of pride to be able to work at an organization at Atrium that really doesn't put any barriers into that. And we provide that care without those barriers. So I really appreciated the history that Dr. Sachs provided, but it helps put a foundational understanding of where we're coming from and where we have to go.
So, obviously, with healthcare, access to healthcare, unless you've been living under a rock, and if you've been living under a rock, I don't know how you have missed the conversation of who should be paying for it, how should we have access. But when all is said and done, we have a system, and the system has to serve people. So I'd like to open this up to all of our guests. What is your opinion of our healthcare system across the United States? And has the ability to access healthcare, has it changed since we've been in the midst of this pandemic?
I'll start, if you don't mind. I think that there are absolutely discrepancies out there with regards to healthcare access. When you're asking, and so when you're asking specifically about healthcare access, though, it's challenging, no doubt. If you really think about it, where does investment occur? Where are the offices built? Where are the services provided? What communities end up getting served? And you end up seeing desperate outcomes. I mean, Dr. Sachs alluded to maternal morbidity and mortality. That was some of my clinical work early on. And some of our most complicated outcomes in the United States are with patients and families of color. And that's unfortunate, and that's something that we're absolutely working to improve. And I think that what all this ends up happening when you talk about access, that it leads to obstacles that further exacerbate those, what we describe as the individual social determinants of health. And it also compiles in their food insecurities, their ability to get transportation, to get to the healthcare destination. And all that contributes to a higher and greater impact that affects our community. But again, I think one of the things that I can, again, speak very proudly of with Atrium is that we've been very intentional about investing where the patients need us the most. I believe in just a conversation with Dr. Stack, she worked in one of those one of our clinics in Biddle Point. You know, Atrium Health has 5 clinics to serve the underserved population within Charlotte. It's in the west part, east part, north sides of Charlotte, and in the inner city. And this represents really about 20% of our community clinics in Mecklenburg County that we serve over 80,000 patients a year. And that when Gene Woods and our team came up with the new mission statement, it really touched us all in the right way. It's to improve health, elevate hope, and advance healing for all. So, and I think it's just even been more exemplified during the COVID crisis.
And Braxton, as you mentioned, we had a system, but unfortunately it's depending of this, what falls under the state law and what falls under federal. And unfortunately for North Carolinians, North Carolina was one of the states that we didn't expand Medicaid. And also we have a lot of residents suffering right now because of that. It's not fair that families has to choose between get covered or feed the families. Also, under the ACA, Medicaid in North Carolina, the federal marketplace is a federal, it's not by a state. So when the COVID-19 hit our state, we were not prepared, but also the federal do not allow to open an special enrollment due to the COVID-19. So that keeps keeping more families out of health insurance. And now, just last week, I had a family that was like struggling because now they have fear that if they go to get treatment for COVID-19, they're going to get bills. And how they are going to afford the bills if they are losing their jobs. So it's kind of like the whole chicken and egg.
Yeah, and I would like to respond to that as well, Braxton. So you asked whether things have gotten worse during the pandemic, and to me, it's as if you look at our healthcare system as a piece of clothing, and you hold it up and you see that it has holes. Well, the pandemic is like shining a light on those holes and just watching them get bigger before your eyes. Some of the things, like Natalie said, even early on in the pandemic, people were afraid to get care. There were many stories about people who had symptoms of COVID and they were afraid to go get tested because they were afraid of the bills. And there were some stories about people who did the right thing and went ahead and got tested and then ended out with emergency room bills for thousands of dollars. But we know that there were also many people who just didn't want the bills and didn't get tested. Well, what do you want in a pandemic? You want, especially early on, you want to identify the people who have it. You want them to get treated and treated early for their own sakes. And you also want them to get identified for the health of the public so that we know who their contacts are, and those people can be tested and they can be quarantined if necessary. That's totally dysfunctional. Another thing I would mention is that there's been people getting less medical care during the course of the pandemic, just general medical care, not necessarily related to COVID. And just last week, the New York Times talked about a study that showed that we thought that a lot of people weren't getting medical care because they didn't want to, their doctor's offices were closed, but they didn't want to go to their doctor's offices because of their fear of infection. But in fact, a much larger reason from that was that people just weren't going for regular medical care because they were worried about the bills. And so COVID has just shown a light on how bad things are, and it has shown us how much worse they are.
Well, can I just add to that, or actually respond to one approach to that? I agree in the sense that a lot of folks were scared to come get care, but part of that worry had to be addressed. And one of the ways we tried to address that in our response in the Charlotte community was to have pop-up testing centers throughout our Charlotte metro area. And even more so, we then created these roving testing centers that once we identified the subset of patients that were even at greater risk, because initially the fears were this was impacting the elderly and the immunocompromised. Later on, we also recognized that, congregate settings and other risk factors of patients were totally being missed. So we actually created these roving testing centers that would go out to hundreds of locations throughout the community where we knew that there were higher risk individuals that we offered it. And we didn't require an appointment or a provider referral to get tested. We ensured that the ability to pay was not an inhibiting factor for the screening and testing. And we not only just went there to screen and test them, because we need to identify patients who are at risk, right? Because otherwise they're going to continue to spread the COVID and potentially infect other members of their family. But we also staff these areas with advanced practice practitioners and social workers, as well as folks with multiple language skills as interpreters, to make sure we addressed more than just the testing need. And I think that's just another one of those huge steps that we took. Thank you. Sorry.
So all of you mentioned some things that can and have changed. So, we are in a pandemic is a very disruptive moment, right? It's a disruptive force. And we know that when you introduce disruption into systems, that's when you start to see systems change, right? Whether it's technology, whether it's a germ like we're dealing with now, whether there's an event, there is the silver lining is that you see systems change. But it's often difficult to see that change happen when you're in that event, because you have to fly and build the plane at the same time, right? All three of you kind of exist in a different part of the system. We started kind of talking about how we change things to respond, but how do we change things in the short term during this pandemic? How do we immediately respond to it and change things that can be adapted to meet the long-term system change that is needed in access to healthcare? And I'd love for you to answer that from your own point of view in the system. And Natalie, if you want to start, that'd be great. So what kind of short-term changes can we make right now that will affect the long-term system change?
Well, I'll take that if no one else will.
Oh, no.
So, or did you?
No. Please go ahead, Jessica. I'm sorry. Yes.
Okay. So if we're really, there's some things that communities and so on can do to put some Band-Aids on some things. But I think that if we're thinking about change, we really have to think about our government and about legislation. Now, statewide, the first thing that we should do yesterday, last year, a couple years ago, we should expand Medicaid in the state. That's a real no-brainer. There were 500,000 people who would have benefited from that before the pandemic. And right now, because we haven't expanded Medicaid, many of the people who have recently become unemployed will not be eligible for Medicaid in this state because we don't have the expansion population. If we would expand it like other states, there would be many more eligible. However, that's even the smaller thing. What we really need, we're in the midst of a pandemic. It's a national emergency. It's a worldwide emergency. What we really need is major federal legislation. We've seen trillions of dollars already invested by the federal government in this, and this is a healthcare emergency. We need them to put it in healthcare. Now, there actually are a few bills in Congress, and one of them is, the most comprehensive one is the Healthcare Emergency Guarantee Act, which has been entered in both the House and the Senate. And what that would do is basically pay medical bills for everybody in the country during the course of the pandemic. But for the people who are newly unemployed and uninsured, it would do it by attaching them to Medicare. Now, Medicare is a system that already exists, so you could attach them to the Medicare system and they would be covered. And in the bill, they would be covered without copays or cost sharing so that people would get the care they need. And then to answer your question, Braxton, about something short-term that would lead to long-term, to my mind, by the time we've done that for a year and a half or so during the course of the pandemic, I think that people would see that having healthcare is a good thing, and having their neighbors have healthcare is a good thing. And then I think that we would be able to pass the legislation that would create a Medicare for all system in this country.
Dr. Joy?
Oh, sure, absolutely. Thank you. Well, I think that's from a legislation standpoint. I definitely agree with what Dr. Sachs is saying there. I think from a healthcare industry or healthcare service standpoint, I first want to start off and make sure that we do our fair share in educating. We as a collective, we, the community, any one of us that are advocates for our communities, our families, education is really critical. This is a pandemic. This is now. People are dying. We've lost 120,000 lives in the United States. This is not infected folks. It is infected folks, but they died. I don't want to see that number rise. So let's educate and say, look, we've got the services available to test you, to help identify if you're at greater risk, if you actually have it. We can educate you on what's the right appropriate behavior to socially distance and make sure that we minimize that continuous spread, because we're seeing that spike, we're seeing that surge come back a little bit. Instead of having flattened it and gotten rid of this pandemic, because of different decisions, I'm not going to judge that, we have started to see a curve back up. So we need to educate first, and also let our community recognize that we have the resources to test you and your communities. We're going to come to you. Now, the other part of this was the question of, what are some short-term solutions that we can apply for the longer term? I think what we've noticed over the course of this period of time is we've gotten very good about virtual health. At the healthcare system level, we've used virtual services to help provide care in a much more effective manner. One perfect example would be that we created a virtual hospital. And by doing so, not only did we test these patients, but we were able to monitor them in a virtual setting through our nursing and other services, nursing as well as other healthcare team members. And if they started to show signs of worsening disease, then we would bring them in. Otherwise, they would be at home. The second part of that is if they were sick enough that they really had more severe symptoms, we would actually send our paramedicine team out to evaluate them, treat them at their place. We would go to them. And so treating them at home, treating them as long as they could stay at home from that perspective allowed the interaction of using virtual care, using the paramedicine teammates to also video in, evaluate the patients, provide that care where they were. And then if they were bad enough that needed to come to the hospital setting, we could do that. So this was a proven, this was a way for us to show in this setting, pandemic allowed us to have a proof of concept that we can not only do this work, but we can do it well. And now we can apply it to other non-COVID situations as well. Patients that otherwise can't come into care, maybe we find ways to get out to them and provide these other virtual media to help provide that care.
I want to kind of follow up on that, Dr. Joy.
Sure.
One of the criticisms of our healthcare system is the reliance on market-based, right, for profits, especially around the pharmaceutical companies and their influence on doctors' decisions or hospital decisions and things like that. I don't want to get into the nitty-gritty of that per se, but the COVID has shown a light on has disrupted that portion of the healthcare system, because pharmaceuticals, there was no real, there was no treatment for this virus. We could treat the symptoms, but the number one prescription for preventative care, and even if you do come down with COVID, is not necessarily a medicine. It's a safe place to stay, to go home and isolate yourself, right? You still need to be able to get food and stay fed without going outside. So we see that a healthy city, a healthy neighborhood, a healthy world is reliant on systems that exist outside of the medical services field, outside of the pharmaceutical company. Do you see any, and people who are champions of holistic care will often criticize that they don't get certain things like prescriptions like vitamins per se, or changes in behavior. I know that there have been some trends to change that, as of recent, in the past decade or two. But how are we wrestling with them? How are hospital systems wrestling with giving good prescriptions to their patients, being that they are not necessarily pharmaceutical in nature, if that makes sense?
It does. And I think you ask a really good question, Braxton. I mean, when you come to an advisor, and in this case, whether it's a physician or a healthcare system, you're coming there for advice to get better at what you are. If I told you your primary reason was obesity and one of the best ways to control that obesity was to lose weight, watch what you eat and do that, right? You would say, well, great, but I want some medicine for it. Can I also get the fast magic pill? That's not always the solution, right? And so whether we're talking about that or we're talking about treating COVID, now COVID may not have a magic pill that currently treats it. And really, we want to make sure that we address symptoms. But if they actually need to come in, you do want the healthcare providers and our hospitals to help take care of you. Because if you get it badly enough that you end up in the intensive care unit and need the respiratory support and or other complications that can occur with it, that's where we come in to really help out. And we also help out with all of our other providers out in the community that are providing the rest of that care, making sure you're taking care of yourself, making sure you're also getting the education of social distancing, wearing the masking, doing all the appropriate behaviors to allow it to pass. Because after all, it is a virus that in most patients will pass through, right? And so we have a responsibility to do both. It's not just provide a prescription, but the prescription could also be, here's what you need to go do, rather than here's what you need to go take.
Is that change happening on a systemic basis, or is that just based on if you're in the right place and getting to the right doctor at the right time when they would give you that type of advice?
Well, I would answer that in one of two ways. One, I think it depends on a point in time and where you happen to be, but I also know that we've got a great family physician in Dr. Sachs who served and provided that for how many years? You can ask her. I mean, if people like her were out there doing it for 30 some years, I know we've got other partners just like her in my organization that do that all the time. It's a systemic if we wanted to, and it's systemic only if the patient accepts the advice that's given to them. Not that we're pointing blame, but that's, sometimes we only hear what we want to hear.
Natalie, what do you think of that? I know a lot of the time as patients, we won't see doctors, right? We will see nurses, RNs, and nurses assistants. What is the likelihood that nurses feel empowered to kind of provide holistic healthcare advice or prescribe or push that type of healthcare access to their patients?
Well, here in the US, I do not practice nursing. I'm more on the advocacy and getting the people, the assistants to get access to healthcare. But you make a great point. But also in this community, they are living now in fear. So you need a better approach to get them understand that they need to make their part. Right now, we saw yesterday that the governor approved for the whole North Carolina to wear a mask, and you see all the comments on the social media, like they are doing it for your own good. But there are some criticism and I'm seeing now the comments on the chat right now, and that's the point to get to improve our system is to depolarize a little bit of the healthcare access. We need to stop thinking about the COVID-19 response as a political party or as a political bargain for legislation. So everyone needs to put their part. Atrium and all the other organizations in Charlotte are doing their part, and they are doing a great job opening many facilities all over the city to get access to the testing, to get access to healthcare, as Dr. Joy was mentioning. Now with the virtual visits, they have more options, and they are working right now. So,
Dr. Sachs, I think Natalie brings up that excellent point. One of the biggest barriers to healthcare is knowledge, and I think Dr. Joy said that. This idea that you can get tests, and as Dr. Joy said, they've been responding by putting mobile sites in different places. But we also are getting information that not every testing site is the same. Not every test is the same. Some are free, some have a charge. People look to the city, but when it's a county function. The public health director is not actually an epidemiologist or a doctor, but they deal with public health, which is different than dealing in medicine. Has there ever been, have we seen this as a barrier entry, the education and the rhetoric that is in the public space? Is this unique? Is this a unique time? Or has that always been the case here in America?
Well, this is definitely a unique time. I mean, it's definitely a unique time in many ways. And just one of the things that I would say about the confusion about this in particular is people complain sometimes, like I've heard people complain. They said not to wear masks, then they said to wear masks. We're dealing with a brand new virus that we're not familiar with. And so the knowledge about it is evolving. And that's why recommendations change all the time. It's not anybody's malice about it. And it's not anybody deliberately trying to confuse. But, one day studies show this, and then there are new studies. And so we're trying to inform people in that kind of way. But in terms of confusion about healthcare in general and what to do, I mean, that's a longstanding problem. And there are all kinds of layers to that. I mean, one of the things that I felt in practice was that could be of some help to that is that if people have primary care providers and they have a relationship with them, then they ought to have a trusted place that they could call to sort out information like that. And it would go something like, do I need a test? And if so, which one? And where would you recommend that I go? Or what do you think about this or that? I mean, it helps to have somebody that you really trust to get that kind of information from.
Braxton, can I add to what Natalie was talking about? Just one other item. It's not just the physician that you would go seek. It's really our healthcare team. And we've really become the team model to incorporate not only our nursing members, not only our social workers, not only our advanced practice providers. It's the holistic team that provides the care for the patient when they call in, and we respond as a team as well. And so when that patient is calling and asking for advice, that is the team, and we count on each one of them. The other thing I would just add is we currently have 2 roving sites that go out and provide 8 days per week of service, soon to expand that up to 10 days of service, and then the plans are in the near future to expand to a 3rd mobile vehicle that will allow us up to 15 days. And the reality there is right now, on average, we're testing over 250 people per day, with the highest being about 288 patients this past week, which is great because these, again, no appointments necessary. We want to provide access to care, and this is our approach to do that. And but what's worrying me, and that I want to make sure that I ask you to help out and this group to help out, is that we're seeing a decline in some of the African-American patients coming in for testing at our roving sites, which is concerning, right? Concerning because there's a disproportionate risk amongst our African-American, amongst our Hispanic Americans, our people of color, et cetera. And we're really committed to eliminating the disparities in testing. And that's why we're engaging leaders like yourself. And my role is dual-fold here. One is as the chief medical officer for the Quaternary Center, which will help take care of the sickest of the sick. But I don't really want you to get sick if you don't need to be, right? And so please go get tested and, be vigilant in all the rules that have been put forth regarding the masking, regarding the social distancing, the hand hygiene. But really, if you have any symptoms or any concerns, come get tested. I mean, we want to make it easy for you.
So since we're on the subject, Dr. Joy, I know you mentioned that we have those. There are a lot of questions in the chat. And just for clarity's sake, how do people find out where these roving sites are, and how do they access them?
Yeah, we post them at a week at a time, and it's really not. I'll have to get back to you on that as to the easy access point of how to get that information up there. but we try to make sure we're strategic so that we're not always going to one part of town, right? We want to be able to divvy this out into different different environments. But I'll get back to you on that.
So for the folks that have that question, at Levine Museum of the New South, we do follow-ups for the questions that don't get answered. So keep an eye out for that. Hit share when we do post that. You can hit share right now to help keep people informed about this important information. So I'm sure that will be one of the follow-ups that we provide and we put out to our audience, where we can find those mobile COVID test sites week to week, at least for Atrium. I do want to, one question, I know we're running out of time. I know we talk about this from a Charlotte-centric point of view, but specifically around COVID in North Carolina, this is a strain for all healthcare networks. But one of the concerns that I had going into this was the ability for rural healthcare networks to have the type of capacity. Specifically in North Carolina, with that lack of Medicaid expansion, millions and millions of dollars have come out of those hospital systems, especially in rural North Carolina. Many have closed, so that some counties have to rely on healthcare systems in other counties. Can any of you talk to what we are seeing in terms of access to healthcare in those rural networks? Are we seeing people coming from our surrounding rural counties? Are they coming into Charlotte? And what do we look forward to over these next few months as we continue to deal with these waves?
Can I take a quick step at it from an Atrium perspective for sure?
Please.
We have many of these pop-up sites at many of our other facilities. For example, out in Stanley County, we have a pop-up site there that allows some testing there. In Monroe, we have a testing site. In Cleveland, we have a Shelby, Atrium Health Cleveland has a site. So we've made sure that we also take into account our rural areas to make sure that the net is wide. And then to the first part of your question from a more of a North Carolina perspective, we are very involved with the North Carolina Hospital Association, and there are a group of physicians and administrators and hospital execs who are trying to make sure that each of the other hospitals throughout the state also communicate on our challenges and what current status we're in and being able to deliver the care, and then help one another out whenever possible.
Braxton, if I can add something, we as a member of the community, we need to step up and do more advocacy regarding Medicaid expansion and protecting the ACA. Our state is more vulnerable during this pandemic, but it's not too late for legislation to do the right thing. We need to, like Dr. Joy was mentioned before, we need to educate ourselves and promote Medicaid expansion. Call your legislature, call your Senate and your representative and ask for a Medicaid expansion in North Carolina. We really need it. Work with the regional VA healthcare facilities to eliminate barriers, but also to help mixed status families that do not understand yet that their U.S. citizen children are allowed to get benefits and are allowed to get healthcare access.
So we have a follow-up from directly to you, Dr. Joy. Where does Atrium stand? And if you know, where does Novant stand? Do you lobby for Medicaid expansion, or is that something that you'll stay out of?
I don't know the exact answer for that, so I don't want to answer incorrectly for my organization, if you don't mind.
Absolutely. Dr. Sachs, do you know? Traditionally, if not those specific examples, would have medical systems?
I do know that several years ago, when it was being discussed, that the heads of all the large hospital systems in North Carolina went to Raleigh to lobby for Medicaid expansion. I mean, that's generally the stand of hospitals, because Medicaid expansion, besides insuring all the uninsured, also allows them to get reimbursement for patients who otherwise would be uninsured.
Yeah, expanding Medicaid will ensure health access for all, but also will bring millions to our economy in North Carolina. So it's kind of like a win-win situation, but unfortunately is being played around as a bargaining tool for political parties.
So for the audience out there, just to answer the question about how do you access where those Atrium testing sites are, the best, you can directly get there if you put in your search bar mobile coronavirus testing at atriumhealth.org. So mobile coronavirus testing at atriumhealth.org. As Dr. Joy was saying, those locations and times change week to week as they try to move around. So what's happening today is not going to be the same as what's happening tomorrow. So make sure you do that search and check those sites week to week. I will say I've taken myself 2 coronavirus tests, one at Atrium and one at the Novant site. While they were uncomfortable, they were very accessible for me. I did the same thing. I just put in the search for the days that I felt like I needed to go get it, and I did it, and it was taken care of. Might have also found a new primary healthcare provider because I don't have one yet. So speaking about access to healthcare. So with that said, Natalie, how do we, how can members of the community help advocate for better access to healthcare? As you said, this does get mired in the political discussion, and a lot of people honestly don't want to be bothered with that, but they do want to be able to go to the doctor. So what is an effective way for somebody to do that in our community?
So I would recommend first educate yourself. Like, do not believe what all the media or the news are saying about the Medicare expansion, but educate yourself. Like, talk to experts. Also, promote Medicaid expansion with your friends. Protecting ACA. Ensure access to quality health care for Medicaid recipients under the North Carolina overhaul Medicaid program. Vote. That's one of the main points. We are seeing a lot of decreased voting lately, so please vote. We have an election this year that is very important, so vote and just work with organizations. We are Charlotte Center for Legal Advocacy. We are always advocate for our community. We have a navigator team that can answer all your questions. Right now, we have several people that are losing their jobs and they do not know how to navigate the system. So while they're losing their jobs, that meaning that they are losing also health coverage through that job. So please reach out to us if you have any questions. If you are not sure that you qualify for any of the programs that North Carolina has, one of our navigators are more than happy to help you.
Yes, and I would agree with advocating for Medicaid expansion and educating oneself. And for Medicaid expansion, you should speak to your state legislators, your own, other people's, get them all to vote for it. And of course, additionally, I would really recommend that you talk to your people in Congress, your congressmen and senators, about national legislation and about getting really comprehensive healthcare legislation through Congress, because that's what will really help people in the country. And if you go to our website, which you should see shortly, there you go, healthcarejusticenc.org. If you join us by signing our resolution that you agree with us, you'll get updates from us, which will tell you about pending legislation. And we often deal with when Medicaid expansion is coming up, as well as the national efforts.
Dr. Joy, you mentioned the use of telehealth. We also know that in North Carolina, across the country, we have an expansive digital divide. A lot of people don't, even to this day, don't have access to high-speed internet. Honestly, 2 out of 10 people in Charlotte still don't have that at home. And in some parts of Charlotte, that number can reach up to 40%. Even if people do have access, quite often they don't have the actual devices that are necessary to fully participate. So even if they might not have a laptop, but they might have a phone, but their phone might not be sufficient to deal with everything. And then even if they do have those 2 things, lots of people don't know how to use those as tools. They haven't been educated of how to use those tools. Since in COVID and moving forward, it seems like we're going to be going by the way of telehealth. And when you get into the more internal aspects of things, we know that newer technology like 5G is going to be necessary to get the full medical experience that is necessary. Is this going to be the next divide that is going to separate people from accessing healthcare? And if so, what is the industry looking at doing to help bridge this gap?
Yeah, that's a great point, Braxton. I think that there are many divides, right? I think we've got lots of other conversations that are going on, and rightfully so, in the United States that deals with a big injustice divide as well. I think the healthcare divide, as it relates to, is only tip of the iceberg. I think our president, Gene Woods, in a LinkedIn article last week spoke of the Juneteenth and described that this is really, again, the tip of the iceberg when you talk about healthcare access, because it's really the disparities in health are linked to the disparities in wealth. And so you're describing, okay, if you don't have access to 5G or you don't have access to broadband, those are just other mechanisms of either service industries not being able to provide that for certain sectors, but it does impact the way we deliver care. I mean, the first question we talked about is access based on where you're geographically situated and you have transportation access and so forth. So, organizationally, all I know is we're doing many steps to try to help narrow that disparity in wealth. This past year, we raised our minimum wage to $13.50 an hour, and we're plans to get it up to $15 by 2021. We've as an organization, we've helped commit $10 million to increase affordable housing. We've invested $2 billion a year in community benefits. I mean, so organizationally, we're trying to narrow that divide. Can we solve it alone? No. But will we need a community effort to kind of address those issues? Because guess what? As a healthcare industry by itself, we are experts in one area of the community well-being, right? These others are financial. These others are social. And we're willing to and ready to partner with the community as a whole, the state as a whole, to make that divide narrow and hopefully eliminate it with time.
Thank you for that. I think we'll probably got time for about 2 more questions. And I know we've been talking about a lot of the challenges that we face as a nation, as a healthcare system. But there's 2 versions to a story, right? There's many versions to a story.
Yeah.
What is promising? What are we seeing that is good, and things that we can do more of? I'd love to hear all 3 of you, your perspectives on this. But I would love to let Natalie start it unless somebody else feels so compelled.
So I think that one thing that I get from this crisis is like how the whole community responds and how all the different organizations around Charlotte step up and try to help. I know our organization at Charlotte Center for Legal Advocacy, since all the main offices for getting access to healthcare and public benefits closed down, we came up with ideas to reach our community, to help to navigate to get the assistance or to apply for different benefits that they do not know how to do it. Sometimes just the building, like the DSS building or the health department, is kind of like intimidated, but we are trying to smooth that process and help consumers to actually that they are losing their jobs. They do not have the meaning to feed their families, how to get all these benefits and how to get all the access. Since the Mecklenburg County DSS closed on March 18, we assist more than 200 families through this process. And I think that's one of the positive points that the COVID-19 is, like how the whole community and the different organizations step up and are helping each other.
And if anybody wants more information or wants to help or needs help, just below us, that Navigator phone line for CCLA is scrolling past, and you can call them for free and be pointed to more information.
Thank you, Braxton.
Dr. Sachs?
Yeah. Dr. Sachs, what are we doing well?
So what are we doing well? If your question is where we see hope, I'll tell you where I'm seeing some hope these days, which is we have these two pandemics. We've got the COVID-19 pandemic, and then in the aftermath of the George Floyd killing, which was murder, which was yet one more. I think that's really demonstrated the other pandemic of racial injustice. And what I think, that I say this cautiously, but I think that there is a real opening up to what an injustice that's been. And I see these things as very related because both of them have to do with racial injustice. The reason that African Americans are being infected and are dying at higher rates has to do with the way that they've been treated traditionally. And so where I see some hope is in the idea that both of these are helping the public to open our minds and maybe be open to some broader, more comprehensive solutions than we have in the past.
Yeah. And my thoughts are, I love referring to history leaders, and one of them that stands out to me is Gandhi and his comment of, "You must be the change you wish to see in the world." That sticks out to me because I'm seeing a lot of change right now, and it's incredibly uplifting because we see so much goodness by so many people. When the pandemic came through, we saw the community band together. We saw hospitals system, even in Charlotte, work together to come and make sure we had the infrastructure or a solution in place to address the surge by even having community field hospitals if needed. I saw people, and we've seen hundreds, if not thousands of people, show their gratitude for and to one another that we may not have otherwise seen. Quite honestly, I've also had a lot of time with my family at home that I would have otherwise not seen too, because this has really allowed us to get back to who we really are as a human being. And so I'm incredibly excited about what can be. The area that I'm a little cautious about, though, Braxton and Dr. Sachs and Natalie, is that I pointed out that we are starting to see a little surge back up, curving back up in the pandemic, and that's carelessness, and that's behavior that we can control, and that's not education. And there's another quote that I absolutely love, which is by Albert Einstein: "Is insanity, the definition of insanity is doing the same thing over and over again and expecting a different result." And in my mind, if we allow this to go up and have unnecessary death, that's just insanity. But I do like the fact that we took some action. I like the fact that Governor Cooper and even Gene Woods was on with him yesterday, where he and our organization and the Charlotte and the CEO Council made a commitment to 1 million masks strategy for our community to continue to reinforce this necessary action of masking and distancing and washing of one's hands. So I see hope. I just don't want to see insanity.
Well, thank you. Thank you all for that. We're going to get out of here with one last question. And since we are a history museum, we always like to ground this conversation in history. So what does history tell us that we should keep in mind as we move forward as it relates to figuring out this access to healthcare? You might not have heard that, but what does history tell us that we should keep in mind as we move forward? And Natalie, Dr. Joy, and Dr. Sachs.
Dr. Joy can answer first.
I think history tells us we are prone to go back to our own bad behaviors. That's just a human tendency. We all regress back to the mean if we allow it to, and change requires a lot of effort and a lot of commitment. And I think that's where I see the brightness, and I see a possibility that a lot of us are really adhering to some change, and quite honestly, we'll need to. And I think that I'll give you an example of tied into the pandemic. If we compare the North Carolina population of 10.5 million and the South Carolina population of about 5 million people, we've had 56,000 cases and 12,000 deaths in North Carolina, and in South Carolina, 26,000 cases and 673 deaths in South Carolina. So the reason I gave you that actual example of that is we look back and go, you know what? History tells us Taiwan, who was only 81 miles away from China, and they responded as soon as they had the information about this, before it was even called coronavirus 19. They responded by implementing all these changes, and they have a population of 24 million. Do you want to take a guess at how many deaths they've had in their country? 24 million people, 7 deaths. All right? Because they learned from 2003 when they underwent the SARS epidemic and all the complications there, and they were prepared. They worked together. And I think we can work together. We flattened the curve before. We can get it back down to controlling and not losing any more lives.
And now that you mentioned history, I saw, I think 2 weeks ago, a post about the 1920 Spanish flu and the pandemic at that time, that how they flat the curve, but later they start like doing over the same thing, and they by the fall the curve increase again. Yep. So we are seeing right now the same example. So as Dr. Joy mentioned it before, is doing the same thing without learning anything. So we need to make our part. As I mentioned it before, if we want to celebrate Christmas, we need to keep the distance, wash our hands, and wear a mask.
Okay, and thank you. And to expound, add a little to what Dr. Joy said about Taiwan, one of the reasons that Taiwan was able to be so successful was because they used their national data system. They had everybody in the country on a national data system. Well, you can only do that if you actually have a national system, yeah. Which they do. They have a national single-payer system. So Dr. Joy also was talking about quotes. So there's a quote from Winston Churchill that goes something like, the United States always does the right thing after they've tried everything else. So I think that this is a good example of, I started out by giving you the history for the History Museum of the last 100 years. And I would say we've tried about everything else. And what I hope that we learn from this, and what we learn for us to be better prepared for the next time, is that we need to join other developed countries, and we need to have a national system where everybody is covered, and where we're prepared the next time, where everybody can get the care that they need.
And I will add that without the fear that because of their race or their nationality, they will be judged.
Agreed. Thank you, Natalie.
Yeah.
Totally agree.
So do I.
Well, thank you all. Thank you all for being our guests. Thank you all out there who are watching for supporting our mission by attending this Shaping Charlotte event. We are honored that we can continue to host conversations around important issues of today, and appreciate your support so we can continue to do so. Of course, that thanks goes out to our sponsors, Bank of America and Arts and Science Council, but I would definitely want to remind you that we rely on our audience. And we don't just rely on our audience to watch and to give. We rely on our audience to participate. Dr. Sachs, for instance, is a member of our museum, and Dr. Joy is one of our newest board members. So we rely on our community's input on all of our levels. So please see the links shown in the comments section on the final slide for tonight for ways that you can support Levine of the New South while our doors are physically closed, because as you can see, we are still always open. So my name is Braxton Winston. I am the Community Connections Manager here at Levine Museum of the New South. I want to thank you all for joining us tonight, and keep a lookout for more new exciting programming that will be coming in the coming weeks. Thank you all.
Thank you.
Thank you. Thank you.